All right. So, ECG part 2. This will be meeting on Dashera also. Day after tomorrow. Now, today's session will be like, I won't say complicated, but yes, you have to understand it properly. Once you have understood it, many of the decisions you'll be able to take within 5 seconds. And I'll be giving you several practice ECGs also. Try to participate as much as possible. Because today's ECG is like a transition. We'll not be discussing any of the condition today, but what we'll be discussing is, that is all those axes which you learned. We'll see its practical implementation on the ECG. Once you have understood it, once you have understood that, okay, this is 1, 2, 3, AVR, AVL, AVR, V1, V2, V3, V4, V5, V6. And that's how we have to interpret it. The next session is going to be extremely easy because first day we learned the fundamentals and today we will be learning the implementation of it. Okay. All right. So let's start with many are there. Okay, we wait for a minute or two. So meantime, we'll very rapidly we'll go for the revision. So in ECG, we said that there was SA node, then there was AV node, correct? And then there was one extra branch. This was the branch which was for left atrium, right? That is the Buckman's bundle. Buckman's bundle. And then there was bundle of his which was getting divided into 2 parts, right? And then it was giving all the way to the right and the left ventricle, correct? So we were having that bundle of his which was dividing into the right bundle branch and the left bundle branch. Right bundle branch and left bundle branch, and then there were Purkinje fibers. Correct. All we need to understand in this is that this is the area which was for right atrium, this was the area which was for left atrium, this is the area which will be for right ventricle, and this is for left ventricle. This figure is not in proportion, right? Yes, we know that left ventricle is bigger, so it has to be something like this big, but this is for understanding. So far, all fine. Each SA node will reset AV node. Otherwise, if SA node is not working, then AV node will start working. The concept is, we have to watch the current, right? The ECG is nothing but it is the display of current, because we cannot see the current, but its effect on the muscle can be seen. So that's the basic principle behind the entire ECG. Right? What we'll be watching is the effect of current on muscles. Also, you have to remember one more thing. You must have seen what is called as the tug of war. Right? Tug of war. There is a rope, right? That's the central line, and then there is a team A, and all of them, right? They are pulling, right? They are pulling. Similarly, there would be team B over here, and they are also pulling. So that rope is pulled either on this side or on that side. That's how it goes. Right? So that's how it goes. 2 things. When we find that the rope is going on this side, it means we have to interpret it in this way, that either the B is strong or the A is weak. Right? You got it? That when things are in balance, so then things are in center. So that means A and B are same. But when we see that the rope is moving in this direction, so for some reason, B is getting strong or A is getting weak. So for example, in our case, we will say that when it is a shift, so either there is hypertrophy or on the opposite side, there is myocardial infarction. You'll see that, we'll see this thing, but this is just the concept what you have to remember. Right? Exactly the same thing will be implemented one after the another on every ECG. All right, now I think it's time. All right, so now this should be very clear to you. This was the phase 4, right? That is where we started, and this is the phase of repolarization. Right? Repolarization. Because over here also this will be the phase 4, repolarization, when everything comes in, it gets settled. And then we are talking about this what? We are talking about cardiac muscle. Right? In cardiac muscle, its specialty was gap junction. So gap junction was getting what? Gap junction was getting the sodium and potassium from the either from the pacemaker or from the nearby cell, and that's how it was coming out. Right? So because of that gap junction, right, it started rising, and then there was a phase of depolarization. That depolarization, that is in which there was large amount of sodium which was entering, right, and it was on the voltage gated channel, right, sodium also, and this calcium also. Then at one point this sodium stops, but this calcium, right, so that calcium, that is continuously working, right, and over here at this junction, even the potassium channel, that also starts. So now it is like the calcium is going in and the potassium is going out, and this is the phase of plateau. This is the phase in which we are interested. This is the phase of contraction, right? That is where the contraction would occur. So now you can really imagine that if there is less calcium, right? If there is less calcium, so yes, immediately what would happen? Less calcium, so this plateau won't be able to sustain, correct? Because see, potassium is working, potassium is thrown out, so immediately I'll take it in another color, it will drop. So that means the contraction has decreased, correct? The contraction has decreased. Or in other way, what if there is less potassium? So if there is less potassium, that means calcium is coming in. But potassium, it is unable to take it down, right? So then this thing would be extended, and then it will come down. So here you can see that just from this much, and this thing will be reflected into the ECG. So, and it makes sense because if there is more calcium, right, more calcium, so it will be causing more contraction. So what will happen when we will be learning the pharmacology? We'll be just controlling all these channels. Whether we want to block the calcium channel, the moment we block the calcium channel, immediately potassium for that, right, it will take it down so that the contraction has decreased. Muscle is getting rest, right? Because muscle is into the infarction. Muscle is already bichara mara hua, right? So we don't want to make it work more. So that's why if we block the calcium, that means calcium won't go in, it won't trigger that much contraction. So whatever is needed, that much it will do, but not the extra, and that's how we give the rest. All these things will come in pharmacology, but these are the concepts, because we are going to watch when the calcium is level, the level is less, so it is called hypocalcemia, right? When the potassium is less, so we'll say hypokalemia. So if they can cause changes into this membrane potential, so obviously they will be making some changes even into our ECG. So this was one. There was one email that I'll explain it over here. It is called as the CICR. CICR means calcium induced calcium release. What I was trying to explain last time was when the amount of calcium, say here is the cell, right? Very crudely we are making that this is the calcium cell. The amount of calcium which is entering into the cell, it is very It is not sufficient. It is not sufficient to cause a powerful contraction. But in every cell, there is something which is called as the sarcoplasmic reticulum. Sarcoplasmic reticulum. This sarcoplasmic reticulum is the source, is the storage of calcium. Right? And this storage of calcium, it is locked. Its key is this calcium. So the calcium which comes from the outside, though it is less, it is small, and it has come because of the trigger of the voltage gated calcium channel. It will open this lock, and once this lock is opened, the large amount of calcium, it is released into the cytoplasm, and that is what leads to the contraction. Okay? So that's why this is called as calcium-induced calcium release. Small quantity of calcium which has entered into the cell, it triggers large quantity of calcium, and that is the calcium. When it is released, it will lead to muscle contraction. Muscle contraction. Question: does high blood pressure cause change in ECG detection? You will get the answer today only, because from ECG we cannot say that the blood pressure will be, say, 160 over 92. No, it cannot be said. Right? But when we say, now you are senior enough to tell, and when we talk about the blood pressure, so there can be two types of blood pressure and two blood pressures. Which two blood pressure we are talking about? Systolic, diastolic. Systolic, diastolic, that's fine. But which two blood pressure we are talking about? First, 83. Start answering. I'm telling you, participate today. Right? Today, when I ask a question, start typing. High and low nahi. Hypo iso nahi. Yes, Vedant. Hardik, complete the answer. 120/80 is systolic, diastolic. When we are talking about blood pressure, there are two important blood pressure, two types, systemic and pulmonary. That's right. Who has answered it? Shweta. Okay, got it. Systemic and pulmonary. And can you just tell me two differences between systemic and pulmonary? Very fast, quickly. Two differences. Yeah, one is fast, one is slow. The systemic is fast, pulmonary is slow. Other difference, low pressure differences. Right? This is like 120 over 80, but this is in just 20, 10 and 20, right? Oxygenated and deoxygenated. Yes, you can take that. Okay, so now you know the difference. So when we talk about whether it is pulmonary or systemic, in systemic blood pressure, when there is systemic hypertension, right? So when we say, yes, perfect. So yes, when we say systemic blood pressure, right? So when we say high blood pressure, right? So routinely we talk about the systemic. We talk about the systemic. So this systemic hypertension will lead to enlargement of which chamber? Systemic hypertension will lead to enlargement of which chamber? Which chamber? Very good. That's right. Left ventricle. Shweta, right ventricle, left ventricle, na? Because those right ventricle from there to it goes that pulmonary. Na? I said pulmonary. In exam also I asked this question, right? Pulmonary circulation. Correct. Yeah. So it is the left ventricle. That means higher the blood pressure, higher will be the left ventricle size. Now there is a very big difference between left atrium and left ventricle. You must have marked when we said that left atrial enlargement. Left atrial enlargement. And when we talked about left atrial enlargement, and when we talked about left ventricle, we say left ventricle hypertrophy. You know? These are the two things. So why so? Left atrial as such. That's right. Left atrial enlargement would lead to dysphagia, right? That is what is called as the cardiovascular dysphagia. Left atrium's wall itself is very thin. So even if there is pressure, its size would increase, but the wall thickness will not be much affected. While in case of left ventricle, the wall thickness that is already big, already thick. So when there is increased pressure, so they become hypertrophic. It means whenever there would be left atrial enlargement, because the amount of muscles, so they are same now. Right? So you can say something like this, that this is our left atrium. So when it is enlarged, it will become like this. It has become bigger and it will cause all those pressure symptoms. Yes, that's right. What you say is dysphagia. It will be compressing that esophagus which was behind. So person will be getting the dysphagia. But when it will come to left ventricle has got the beautiful muscle mass. Right? Beautiful muscle mass. When that is enlarged, when that becomes bigger, so its muscle mass becomes bigger. Because it has got those muscles, so these muscles, they become bigger, and that's why this is called as the left ventricular hypertrophy. Whenever there is hypertrophy, that means more muscles, so more current, more muscles, then there is more current, that means the wave which was like this, that wave will become like this, right? So there will be, if we say this is Q, this is R, then we'll say tall R. Correct? Makes sense? Tall R. Now this tall R, in which lead? Well, the lead which is watching it, right? Which lead will be watching it? If we draw it over here, the real axis exact is like this, and this is which one? This is lead 2, right? Lead 2, because that was like this. This is lead 1, this is lead 2, this is lead 3. So that means lead 2 is exactly in the same electrical axis. Remember it, right? I'll speak again. Lead 2 is parallel to the electrical axis of the heart. So when we draw the heart, like this, right? When we draw the heart like this is how the heart is, right? So then the electrical axis is this. Electrical axis means what? The maximum number of muscles. When the current really is going from SA node to AV node to those bundles, so the direction of the current, it is going in this direction, right? And who is watching this? Our lead 2 is watching this. Right? Lead 3 is over here. Over here, it is our AVF. Over here, it is our lead 1, right? So that's the lead 1. That's the lead 1. This is lead 2, and this is lead 3. The different gap of 60 degrees each. Yeah, towards 60 degrees. Correct. So whenever there would be this muscle, if it is enlarged, right? This muscle. So if there is more muscle, so then we'll be getting a bigger spike into lead 2. Because lead 2 is watching directly. So all the current, whatever is coming, right? It is experienced by lead 2. Lead 3 is watching from the side. Lead 1 is watching from the top. So over here, the concept of vector would come into picture, right? So last time we talked about vector. So vector is like, say, if this is a stone, right? And we say that if one is pulling from here, one is pulling from here, so the stone will go in this direction. Totally agree. But what if the person who is here is, this is A and this is B? If the strength of B is double than the strength of A. Strength of B is double as compared to strength of A. So at what angle? Right? So at what angle the stone would go? Here is the stone. Towards A? Mohammed, now you are correct. Sarthak, you are very accurate. Very good. More answers? Question is, this is A, this is a stone. A is pulling, B is pulling, but the strength of the B is double than the strength of A. So what would be the direction of the stone? In which direction it will move? At what angle? Upward, definitely. Yes, it will be upward, right? Diagonal. That is also, but at what angle? Can anyone see the angle? Right. Okay. Okay. Shweta, think again. Right. So this would be 30. Right. Okay, more than 45. Will incline towards B. Okay, it would. Now you all are coming to correctly. This would be 60, correct? Because say it would be towards, this is, if I take this to B, right? So if I just convert it into that, strength of A is 1 and strength of B is double than A. So we just write 2A, that comes to 3A. So this means with this 90 degree, if we divide it to 3 parts, so 2 parts towards the B, and so that's why the stone will be going into this direction. That's right. This is the vector. So up till now, what we were understanding is vector was just it goes in meter, but it depends upon the force. Same thing would happen over here, right? So when this 3 will be watching, that how much current is going over there, and accordingly over here also the size of the wave would increase, but it won't increase to that much as much as 2 is, because for 2 the current is coming straight away. Yes, I many times use this thing, that ECG leads, right? ECG leads, they are nothing but they are like you must have seen those CCTV, right? CCTVs. So ECG leads are nothing but they are like multi-cam operations, right? Multiple cameras, they are watching the ECG, watching the heart, and the representation of it is nothing but the ECG. Another simple concept. We are here, this, right? This is A, this is B, and we are over here. So as the signal comes, so it goes plus. As the signal goes, right? As it goes, so it comes minus. Right? So this is because it goes, so it is going down. As it comes near, it is up. Correct. So positive and negative deflection, they are simply telling us one thing. Right? They are simply telling us one thing, that whether the signal is coming or going. That's what is the way with respect to this point. Right? With respect to this point. The basic waves. Right? The basic waves, when we say this P, Q, R, S, T, and at times the U. We'll talk about the U also. Which question are you talking about? Anyway, let's take this. Right? This is P, this is Q, this is R, this is S, this is T, and at times U. Right? This U. Not every time it is present, but at times we can really see it. So in our ECGs, whenever we'll see it, we'll be talking about it. Right? But the most important would be the P and the QRS. Right? And then there will be the ST segment. So here, for any of the ECG, 2 things. One, we must know which pacemaker is working. Now, in normal conditions, so it is like our SMM is working. So if we take your ECG, my ECG, right, we will find that yes, it is beating at a normal pace. So we say it normal sinus rhythm. Many times on ECG, on emergency, or they just write NSR. NSR stands for that everything is fine. It is called as the normal sinus rhythm. So in order to see this thing, what we need to calculate? We need to calculate the heart rate. That is what we will now be doing, right, to calculate the heart rate. The second is, we need to find the direction of the current. Direction of the current. So if it is normal rhythm, then direction of the current will be completely fine, right? And we'll see only some of the leads which we have to see. But one thing is very clear, that in AVR, the appearance would be totally reverse. Correct? AVR, it would be the complete reverse ECG. Right? Upside down. Right? I'll write it upside down. And you know the reason also. And in case if it is not, then it will be even more clear as we discuss it today. So far, all good. This was when we discussed about the entire cycle, right? What is happening at what level. One another word you will find in ECG report, whenever it is said isoelectric, this word, even we'll be using this word. Right? Isoelectric means at the same level. So P, and now this phase, right? And then the QRS, this is some activity going on, right? This phase is isoelectric. This phase. Another thing you have to watch at times. Tell me how things would really go when there is hypertrophy. Right? When there is hypertrophy. So that means over here, it would be a big wave. Right? But if someone is watching this entire event from here, so then he'll see what? That yes, signal is coming, right? He'll see that signal is coming, and then the signal is going. So for them, it would be upward deflection, right? And then the downward deflection. It would be the same, right? Because whatever the amount of current which is coming and whatever the amount of current which is going, it is same. So it is just like this. So here, the upward movement and the downward movement, they will be same. Right? Upward and downward movement, they will be same. Just keep this thing in mind, because we are watching this thing from 90-degree angle. Right? 90 degree. It is like on the railway platform. We are just standing and the train is coming and then it is going. Right? So first, right? And why such wave? Why such wave? The wave is, think of that if the train is coming from the far distance, right? First, its sound will start rising, right? And if it is whistling, right, it will rise, and then as it crosses, right, it will just fade. And once again, it will become isoelectric. Right? Again, the needle will come back to its original position, ready for the next pulse. So just these two things. Over here, these were the phase. That was the beginning, the start. Right? And we are getting P wave over here. P wave was what? P wave was atrial depolarization. That means atria is contracted. Let's see, the signal has started from SA node. So from SA node it has come, and it is now contracting the atria. As the atria is contracting, so it is pushing the blood from here to here. It is this phase, it is the filling phase, which is going into this process, right? Filling phase. So once this filling phase is complete, that means these ventricles, and these ventricles now they have got sufficient amount of blood, and see all the way the signal goes, and then it goes into this Purkinje fiber. So from bundle of phase to Purkinje fibers, till that point ventricles they are waiting. And then this QRS complex comes. That QRS complex means that is the when the signals will be going into the ventricular muscles, and we call this as the ventricular depolarization. Ventricular depolarization. As soon as the current goes into the ventricles, they start contracting. So they contract, right? They contract, and then once again they relax. So this is the ventricular repolarization. So that is when they relax, ventricles relax, and then the cycle gets repeated. So over here we understood P wave QRS. QRS is ventricular depolarization, that is the QRS complex. Ventricular repolarization, that is T wave, and this one is the atrial depolarization. It is the P wave. Atrial repolarization, it is submerged into the ventricular depolarization because its current is less. Its current is less. So that's the reason that small current, it is merged into the big current of ventricular depolarization. So normally we won't see it. So now if we see it, it's an abnormality. Then we talked about those ECG leads, divided into two parts. One was the unipolar, one was the chest leads. Chest leads, we'll talk more about it today. And the limb leads. Limb leads. Truly speaking, wires, so there are only three. Right? Fourth wire, which is tied onto the right foot, it is just a dummy wire. So in case of limb leads, it is again divided into two parts. One is the bipolar. Right? In case of bipolar, all these things, they are done electronically, not electrically. Electronically, they keep on switching. So this is the bipolar, and the second one is called as the unipolar. Okay. The email which was asked is that bipolar and unipolar, what's the difference between both of them? Bipolar means one end is positive, one end is negative. Take it like your battery. One end is positive, one end is negative. Right? Taking back to physics, if this battery is connected, right, connected with some source, let's say a bulb, when the current starts moving, basically current is what? Current is the flow of electron, right? So this is the minus because the amount of electrons, they are more which are present over here. Right? So it is the flow of current. When we say current, the current goes into this direction, but actually the electrons, they flow into the reverse direction. So that's why when the electrons go opposite, it is the positivity what is deducted. Right? This is when we go back to our physics of 12. But that's the point. There are two poles. Okay. So over here, clearly, there would be like, in case of bipolar, that is bipolar is 1, 2, and 3. And that's where the Einthoven's triangle was coming into picture. Right? So Einthoven's triangle was coming into picture. Now we have to draw it like this. Right? So this is 1, this is 2, this is 3. So here it is the left arm, the right arm, and the left foot. Here. And consider this is always negative and this one is always positive. So problem solved. Right? This is minus, so this will be plus. So that's why the lead 1, that is over there, right? Over there it is at 0 degrees because this is plus. We are just watching it from the plus side. Then this is, so then this is lead 2. Lead 2, which is between right arm and the left foot. Right? As such, we draw it like this, right? Don't get confused. Here, in this case, it is superimposed, right? So, just to make the Cabrera system. Otherwise, it is one and the same. Just we have to watch the direction, right? So, the direction, this is 60 degrees. Right? So, this one would be lead 2 and this one would be lead 3. See the direction. So, from here, so this is from here, that's the direction. and this one is like this, so that one is like this, the direction. So that's the bipolar system. Unipolar means from wherever you are detecting, you just keep it positive, you detect from there, rest all of them, rest of the area, that is turned neutral. That is turned neutral. So all these things, they are called as the AV leads or the augmented. In augmented leads, you need to work on its, so this is what is called as the augmented vector leads, AV leads. So there is AVR, AVL, and AVF, right, left, and foot. Right, foot is left foot. So right, foot, left. Right, this is right, this is left. So these were 1, 2, 3, 4, 5, 6, 6 leads. And in case of chest, all the chest leads, they are unipolar. So we have got all the way V1, V2, V3, V4, V5, and V6. So these were the leads which we talked about. That's what we saw, right? So this is, you know about this part. So this one would be the lead 1. So this is lead 1. And see, this one is the lead 2. And this one is the lead 3. Similarly, see, this one is positive, right? And rest all made negative or the neutral. So that's why the resultant vector is this, and that is AVF. Similarly, over here, this is all made negative. Only this one is kept positive. So that's why this is called as the AVL. Right? So this is for the left, this is for the right, and this is for the foot. Foot means always left. Similarly, this is taken, and that part is turned negative. So rest is all negative, and we are deducting only from one side, and that's how they really go. Combination of 1, 2, and 3, that is what forms Einthoven's triangle. Right? Einthoven's triangle. So anyone who has missed even last time's session, don't worry. Right? We have revised almost everything whatsoever we discussed last time. This was the Kabera system. Now hope you have drawn this thing properly, right? And it is into your mind crisply. Simplifying it at a very good level. So this is 1, this is 2, this is 3. So that means this one would be at an angle of 60, and this one would be at an angle of another 60 degrees. So total is 120. So that means this is 1, 2, and 3. They are at 60 and 120. Easy. About EVF. EVF is 90 degree. Because both of them, they were made negative. So straight away, the first axis is going down. So that is 90 degree. The total is 360 degree. It has to be divided into 3 parts with the gap of 120 degrees. So this is the gap of 120 degrees. So that 120, 90 plus 120, that is 210. But because we are taking it like at this point, 180, and from there, this is plus 180 as well as this is minus 180, and from here it will go towards 0. So 30 degrees more when it is traveled, it is minus 150. And similarly, this is minus 30. But basically, all are at a gap of 120. 120 degrees. So this is whole thing collectively is what is called as the Kabera system. Right? It is called as the Kabera system. We'll be using this thing extensively for all the purposes. One more thing. This lead 1 and this AVL, they will actually be watching what they will be watching. The heart is like this. Right? The heart is like this. So they will be watching the left side of the heart. Right? So they will be watching left lateral side of heart. What about that 2 and 3? 2 and 3 and the AVF, they will be watching the inferior aspect. Right? Inferior aspect of heart. And this R, right, AVR, obviously it will be watching the right side of the heart. Right side of the heart. So whenever there is systemic hypertension, so these AVL and 1, they will be affected more. All set? Okay. Now next is, this is the heart. And we said that for the chest leads, all the way they start. So this is the central line. This is the central line. It starts from here. Right? V1, then the V2, then the V3, then V4, then V5, then V6. By V5 and V6, so they go quite lateral. But these are the leads which are like Z-axis. Right? So we have to really draw it like this, like this, like this, like this. So, but they are into, this is the y-axis, this is the z, this is the x-axis. So then something which is coming out, that is the z-axis, right, which is coming out. So think it like with these chest leads, we are watching the front of the heart. Right? We are watching it from the front. This lead V1 and V2. Over here there is right atrium. Over here there is right ventricle. Right? In between there is septum. Right? In between there is septum. Correct? The septum which is between right atrium and the right ventricle. So that right atrioventricular septum, that thing is beautifully seen by the leads V1 and V2. Am I clear in this? Every time I say this is like one of the question of your seminar. Because rest is all easy. This is where people, they are trapped. Think it this way. We saw na right atrium chota sa, right, and then there is big right ventricle. Right ventricle is our, remember this image. Right? Not, this is not in proportion, but this is right atrium, right ventricle, left ventricle, left atrium. This is the septum which we are talking about. So when if we are watching from the top, so this is how it goes: V1, V2, V3, V4, V5, V6. So this, when the current which is coming, right, see from V1, right, and V2, right, they will be able to watch the current which is coming from the atrioventricular septum directly. So that's the point. And what about this V2, V3? V2, V3, so they will be, see, V2, V3 right in the front. So V2, V3, they will be able to see the interior of the heart. Right? Interior of the heart. Now, interior of the heart is what? Interior of the heart is right ventricle. Correct? Right ventricle. So that would be C. So it would be the right ventricle. Quite easy. And as we go V3, and then as we go from here to here, right, we are going towards left ventricle. Right? So over here, they'll be watching the lateral side of the heart. Lateral side of the heart. And lateral side is left lateral side. Right? Left lateral side. And left lateral side is our left ventricle. Fine. So this was the whole of the Kabera system. Right? So in this Kabera system, this much is now what I am expecting. You must remember this much, correct? And you have to remember this much. AVR plus No, sorry, not this. AVF, AVR, and the AVL. So you have to remember these 6 things, right, with their angles. So this much should be into your mind very properly, right? Very properly. Else, it might happen like suddenly 1 hour we are starting the process, you might get a bit lost into it. So this much part is clear, even if you don't remember, but at least this part is clear. This is what is called as the hexaaxial reference system. In chess system, we are not able to see the array. In chess system means, which chess system? In leads, you're right. You are 100% right. Because left atrium is posteriorly situated, and that's why there are some special cases when the lead is actually dropped from the mouth, right? Yeah, lead is dropped from the mouth, right? And it goes all the way. It goes midway into the esophagus, and then you start recording it. Right? It makes sense now. So here is the left atrium. So here is the esophagus. From esophagus, that leads come over here. That lead comes over here, and then you are taking the ECG. Right? They are all special cases. But yes, you are right. That is in this current system, left atrium. Yes, you will not be able to justify it as good as compared to other. Right? Though there are methods, but yes, I got the point. What you are telling is very right. So here it is. This one 1, this is 2, and this one is 3. That's AVR, AVL, and AVF. This is the Kabira system, right? Kabira system is nothing but it is the on one image only. All the leads, all the limb leads, they are represented. This is what you have to always remember. Right? Nothing new, nothing not difficult at all. Say this makes sense. Visualize. Lead 1, yes, lead 1. Right? So that was the lead 1. Yes, it watches lateral side. Yes, it watches that left lateral side. So this is justified. Right? Then 2 and 3, inferior, bilkul. Right? Then 2 and 3. So they are, this is 2, this is 3. Yes, we are watching the inferior aspect. Yes, so this is also correct. AVR, right side, bilkul. AVL, lateral, right? So this is AVR, this is AVL. So that AVL is watching lateral, yes. And AVF, which was straight away down, so that is watching the inferior. So far, so good. This V1, V2, we just talked about that. This is the septal, right? So it is the septal, atrioventricular septum, right? AV septum we are talking about, AV septum. Then V3, V4, so it is the anterior. Anterior means we are talking about the right ventricle over here, right? We'll be able to see the right ventricle. And V5, V6, as they go on to the side, we'll be able to see the left lateral, right? Left lateral, very true. Right? This left lateral, that left lateral is nothing but the left ventricle, left ventricle. That's how we'll be watching. So that in total, so how many wires are there? How many wires which are connected from ECG machine to the patient? Number of wires are, because this was one of the question. 3 total. Okay, 12, 4, 6, 9, 7. V1, V2, V3, V4, V5, V6, right? 6 wires. And 3 are for limb. Right, that's right. So the total will be 9. श्वेता 15 कैसे बताओ तो, मतलब how come 15? We don't have even that many areas to see. You got it na? See, left arm, right arm, left foot, 3, and these 6 are chest. Bipolar, see, there should not be any confusion. When the patient is there, right, here is the patient. This is right arm, left foot. So when we make, when we say this, so this is what, this is lead 1, this is positive, this is negative. So it is not so that for this negative there is one extra wire. There is already a wire attached. There is already a wire attached, right? But electronically, right, what it is done is, I mean, you are not wrong telling the answer 15, because normally it happens like that only. But this is what is called as the, in CPU, let's use this. In your computer, in CPU, central processing unit, it is just one unit which is working. But you are browsing, you have opened, say, Microsoft Word, right? You are playing some game, and then there is a calculator which is also open. So many things. Right? This is what is called as the multitasking. So it is doing the work of browsing also, it is doing the work of this word also, it is game also, it is also, all the things they are working. But at a very high pace, they will keep on switching at a very high pace. So that's why we'll feel like everything is working. Actually not, right? If there is 1, 2, 3, 4 tasks, so your computer is working on this, and then with microsecond, going for 2, going for 3, going for 4, back to 1, 2, 3, 4, back to 1, 2, 3, 4. And this is when you start giving the priority. So then let's say you give priority to 3, so then this 3 will be given the extra time. So that's why when you really fine-tune your computer, or you fine-tune your routers or the firewall, so you can specify that which packets, right? They are called as the packets, the signals will pick up. You want to give the high priority. But this is the principle. Exactly the same principle, same is happening even in the case of ECG. The leads are 3 only, right? This is 1, that's 2, this is 3. Leads are 3 only, but detecting from this point, right, that means this is the left arm. So it will detect from left arm. At that point, it will make this pole negative. This is positive. Then immediately it will flip. That flip is so fast that you will find that all the graphs, they are going together. So that's the power of processors, right? When we say that we have got the processors which are into gigahertz, so gigahertz, right? So that's what hertz means, 1 cycle per second, right? 1 cycle per second. So this is 1 cycle, right? This is 1 cycle, crest and the trough. So 1 cycle. When we say kilohertz, so such 1028 cycles, right? When it is said megahertz, then it comes to gigahertz, right? So that's how it keeps on increasing. So that means so many cycles per second they are handled, right? And every cycle is a process. So that's why you'll find that everything is occurring together. So your question was, your point was 100% right, that yes, 15 leads, but because it is happening like this, that's why 9 leads, right? So total 9 leads. Now in exam, if there is option of 10 leads, this was a trick. If there is option of 10 leads, so then which one is correct? In real ECG machine, many of them you will find 10 leads. But as we said, that the lead which is going for the right foot, it is a dummy lead. It is dummy. There is nothing connected with it. Right? There is nothing connected. So that's why read the question carefully. If it is asked that how many active leads, then the answer is 9. If it is asked how many total leads, and if you are given the option of 10, then you have to select the 10. Got it? Because this is right foot is a dummy lead. Nothing. There is no electrical activity detected on that end. Okay. Let's start with the ECG part. This is the first look. Right? This is how the ECG would look like. So this is 1. This is lead 1. This is lead 2. This is lead 3. Then this is AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6. So everything is arranged properly. I just zoom. We are focusing only on this much area, right? Initially. So this one would be P, Q, R, S, T. Right? So we are watching all the waves. A very standard, very proper ECG. Just focusing on lead 1, right? So we are watching. Whenever we say that, okay, R interval. This is R. This is R. So then we'll be telling that we are talking about this one. That is what is called as the R interval. Now, few rules always to be remembered, right? Always. The first rule is that the QT interval, when it is said that QT interval, it should not be more than half of R interval. Not complicated at all. Here it is. This is R, right? This is one R. This is another R. Zoom it as much as possible. Achha. Can you see these red lines, right? These boxes. Can you see those boxes which are present? Can you see it properly? Yes. Okay. So you can really see that there is one big box, then there is second box, then there is third box, and then there is some slight area over here and slight over here. So can we really say that what we are getting over here and what we are getting over here is about one full box, second full box, third full box, and then slide over here and slide over here. So overall, there are 4 boxes, 4 big boxes. That's the distance. Right? You can see it over here also, from here to here. Right? So there are 4 big boxes. What's the meaning? We just see in a while. So these are 4 big boxes. Each big box is having 5 smaller boxes. So if you see this is one big box, and in that there are 1, 2, 3, 4. 1, 2, 3, 4. And that's how they are here. Similarly, over here, 1, 2, 3, and 4. So then in one big box, there are 5 small boxes. So total, there would be the 20 small boxes. So that's our R interval. Correct? Now we see we say that QT interval should not be. That's what we put over there. That the QT interval should not be more than RR, half of the RR. Let's find out where is QT. So in this is the P wave, this is the Q, R, S, T. Right? This one is the T. So beginning of T from here to here. Yes, this is this distance. Let's zoom this and draw. This is Q, R, S, and this is T. So this is just this much. So it is just one box, five or six, right? At the most 6 small boxes. So when we say this, the QT interval is 6 box, right? RR is 20 by 2, this is 10, right? So yes, definitely 6 is not more than 10. So that means this is a normal one. This is a normal ECG. Though there are some other things to be seen, but at times when you want to take a quick decision, this is very effective method. It won't be asked in exam ever. No one would ask you this thing, but this is a practical thing. So whenever the ECG comes in your hand, first visually just watch this distance and then visually watch then this distance. This distance is definitely less, right, as compared to half of this. So you have come to one conclusion that things are okay. Next, what you have to watch. What we said is, said which small box did you count? Okay. I'll explain it over here. Anyway, see, that's why I said that can you really see this thing? See the whole ECG paper, it is divided into big boxes, right? Big boxes. You can see that box over here. Just make the pen fine. See this big box, you can see. Right. And can you see there are small boxes inside also? Right? Bus. That is what we are calculating. It is same as graph sheet we used. Exactly, Dunya. Same graph sheet what you use. Right? Same thing. Right? So this big box and the small box. That's the thing. Coming back to this. Now, electric axis. Electric axis. Electric axis of heart is towards which lead? Lead 2. So when we look at the lead 2 will be getting the maximum current. Right? Lead 2 will be getting the maximum current because it is coming towards it. See this, the amount of current over here, definitely lead 2 is getting more. So very easy to say that in case of lead 2, what we'll be watching, that is what is called as the tall QRS. Tall QRS. Because the axis, electric axis of the heart is going straight away towards the lead 2. So that's why we see the tall QRS. It means if this is not present, if we don't find that the lead 2 is having the biggest wave, that means that axis is shifted on either side. Right? Because leads are fixed. Lead 2 is watching from that 60-degree angle, right? Simple. But if it is not getting the maximum signal, that means the heart is being displaced. So signals are going somewhere else, right? That means there is abnormality. So whenever the ECG comes in your hand, first thing, visually, the R distance, how much is it? And this QT interval, yes, this is the first thing. Second, you just go to lead 2, and lead 2, you watch, compare it with lead 1 and lead 3. Right? I'll just remove this, right? So that you can compare. Right? Means there is no big rocket science. Immediately you will find visually the lead 2 is big. Right? So there is tall QRS. So this is the first point. This is the first point. And this one is the second point. Tall QRS. This we are talking about normal. The tall QRS. Is this much clearly is this much clear? Properly understood? Right? Anyone having even slightest of doubt, just let me know. Because from here, now we're going to next level. Right? I'm considering that everyone has understood it properly. Okay. Then comes further needs. Great. So it is, now we are talking about the chest leads. So for V1, V2, V3, V4, V5, V6, right? Here you can see, but which lead will be having the maximum voltage? Which leads? The leads which are watching the left ventricle. So left ventricle was getting watched by V4, V5, V6. Correct? This one. Okay, right? So they were getting watched, right? This one was getting watched. V4, V5, V6. They were watching the left ventricle. V3 nahi. Those V3 is anterior. Right? Our axis of the heart is this, towards the left ventricle. So V3 nahi. Right? V3. I will just see this, because V3 is watching the right ventricle. If V3 is enlarged now, so that means the right ventricle is important. Right? See. Now let's see the ECG. Watch for yourself. Where do you get the large ones, right? So here you'll invariably find that V4, V5, right? And then V6 is going extremely towards the lateral side. So that has again dipped. And see, V3 is enlarged in this case, right? So here, and this is also normal, right? Because V3 was just at the border. So from the exam perspective, take it like this, that you will be getting V3, V4, V5, tall QRS, V6, because it is extremely lateral. So when there would be enlargement of left ventricle, then V6 will also start showing this spike, right? Because the heart will be enlarged. Let me show you. This is the heart, right? So when it is enlarged, so even the V6 will start getting the big signals. So for practical purpose, yes, it is the V3, V4, and V5. V6, let's not write. Clear? So tall QRS, we are getting it. This. So far, all good? So this was the second point. This was the third point. And the fourth point which we'll watch is, watch the AVR. It has to be completely reverse. Reverse of what? The reverse of which lead? to see the reverse of this. See this? This is what is, which will be getting watched, right? So nearest one is this 2. So what 2 will watch, that the signal is coming. For AVR, it would be the completely reverse thing that signal is going away from. So for our practical purpose, what we'll see is this axis and it is this axis. So they both are almost, say, opposite end of each other. So we'll say it would be reverse of lead 2. Reverse of lead 2. So these are the 4 points. These 4 points, that should be your first impression. That should be your first impression. Shweta, you wrote V3, V4 for this thing only. You are right. You are right. So all good. V3, V4. Can you repeat third point? Which third point? This one? Achha, chalo. See. This one. Now I'll take like this. Right. So this will be very clear. V3 is right ventricle, but V3 is quite near to this axial plane, our electrical axis. So V3, V4, and V5, because they are watching into that plane, so that's why their QRS complexes, they will be bigger. QRS complex is what? QRS complex is ventricular depolarization. So that when the current is coming towards ventricle, so they are giving the waves. Right? So that's why, see this, V3, big one, see this one, right? Big QRS. V4, right? See big QRS. This V5, pretty big, but then it starts decreasing. So here it means that heart is quite okay. So these are the 4 points which are to be seen. All right. On to the next one. So we already talked about this small and big, right? Squares. This is the ECG paper. हाँ RR रूल सब में, ये 4 रूल सब में देख रही है, सब में. Right? In every way, you will see this. You have to just, because it will take hardly 5 seconds to see this. And every time when you will see this, your eyes will be trained. The next step is, we have to find out what is the heart rate. So whether the patient is having tachycardia or bradycardia, whether the heart rate is more than 100 or the heart rate is less than 60. Because if the heart rate is less, then, and if it is irregular, then that means that it is, for some reason, heart is slowed down. So then we have to take the history, whether it has been slowed down because of some medicines, or is there anything like a nodal block. Then we have to go into that detail. Okay, coming back to this first thing first, let's find out the heart rate. In order to find out the heart rate, we need to find out that this paper, as soon as you start the ECG machine, that paper will start moving, right? This whole thing, it comes in the form of a roll, ECG roll, right? So that roll, it starts moving, it simply starts moving. Now, the way you, in movies, you must have seen that needle, right? Same way that seismograph, right? When there is earthquake, then that needle moves. Same way, there would be needle, right? It will start moving. Right? Because needle is moving at one point only. As the current comes, so it moves. The current goes, it moves. Right? So current, it keeps on coming, and the paper is moving. So that's how it is. Needle is going like this only, but because the paper is moving, so it is giving all these waves. For the manual machine, right? First you have to shift to 1. you take the ECG, right? So you start. So all the those leads are connected, but it will take only from lead 1 and it is calibrated. Then you stop, then you take lead 2, and then start, and then it is. This is how it is taken manually. In digital ones, all these things they are done automatically, but the paper moves at the speed of 1 inch per second. Right? Remember, it is 1 inch per second. 1 inch is 2.5 centimeters per second. 2.5 centimeters is 25 millimeters per second. This is internationally fixed, right? For any of the machine, this is fixed. So 25 millimeters per second, that much is paper is moving. Now all our squares, right? All our squares, they are equally spaced. They are equally spaced. One big square. Yes, your graph papers, right? Your graph papers. This one big square is 5 millimeter. So we have got this 5 millimeter by 5 millimeter of big circle, big square. So when we say 25 millimeters per second, that means in 1 second, right? In 1 second, this whole thing should really move 3, 2, 3, 4, 5, this much, right? This much paper should really move. Right? This much paper should really move. So 25 millimeter per second. That means 5 big squares per second. In 1 second. So 1 second is equal to 5 big boxes. See, when we say 5 big boxes, so that means 25 small box, because each big box is what? Each big box is 5 small boxes. So far clear? This moves it. There is y-axis and this is x-axis. On x-axis it is the speed, but the y-axis is for voltage. When we say voltage, then our electrical voltage, that is 220 volts, right? 220 volts which we talk about. In the body, the things are in millivolt. It is that less, right? So 1 volt is equal to 1000 millivolt. The paper is detecting. This ECG machine is working on 1 millivolt. 1 millivolt. Right? So how the calibration is done? When the current of 1 millivolt comes, the deflection should be 2 boxes in the vertical plane. This much when it moves. It means what? When the current, you get this deflection. This much. So this much is, you will say 2 boxes, right? 2 boxes. But those 2 boxes are 1 millivolt. Because that's the sensitivity. So it is 1 millivolt. 2 boxes is 1 millivolt. Right? 1000 millivolts will make 1 voltage. So here we are, that's why we are dealing with a very sensitive voltage. So thus ECG is nothing but on the y-axis there is voltage which is into millivolt, and on the x-axis it is the speed, which is in the range of 25 millimeter per second. So far all good, this much. Any query? If not, let's move on to this. 5 big boxes makes 1 second. Right. So how about, because when we find ECG check करने के लिए पिन चेस्ट बॉडी, I mean, no, I'm not clear what exactly you are asking. ECG check करने के लिए pins, chest or other parts of the body? No, nothing is. No. You are not given anything. You are just given the plain paper. ये voltage वगैरह कुछ check करने नहीं. Everything is written onto this ECG paper, right? It is like when you have to understand it, that this is what is called as the calibration. Okay? Calibration means when the technician is taking ECG, at that point he has to really calibrate it in such a way that the needle should deflect. Needle should deflect only 2 squares, exactly 2 squares when the 1 millivolt current is coming out. The way आप कहीं पे blood भेजते हैं patient का, तो the report comes in your hand, right? Report comes in your hand. It is like on a piece of paper, some things are written. Right? They won't be sending you that, right? If it is liver function test, so chalo, send the sample of liver also. If it is renal function test, so send the sample of kidney also. So, bus, it is this simple plain paper. The lines are there, and this is the language of heart. So 5 big boxes is 1 second. So in 1 minute, how many boxes would move? In 1 minute, how many boxes would move? Big boxes. Question is, this is for 1 second. So in 1 minute, how many big boxes would move? That's right, 300 boxes. So 300 big boxes in 1 second. So how many small boxes? How many small boxes? Right? 1500 small boxes. So that's the total distance. Now we have to find out. We have to find out that what is the heart rate. Right? So for heart rate, what we'll be doing is, right, this is very simple now. For heart rate, the total is say 300 divided by, we'll just see 2 consecutive waves, right? Say for example, this is E, R, then E, R, right? So this is 1 R, this is another R. So let's measure the distance between this. So how many such units will be there into 1 minute? That is what we want to find out. So all we need to do is just find out this distance and divide it by it. So number of big boxes between 2 consecutive waves. Right? So this is between 2 consecutive waves. Because that is 1 cardiac cycle. So in 300 boxes, how many such cardiac cycles are coming? That is your heart rate. Right? So because this is 1 cardiac cycle. Let's take this. Let's take this. So take this wave, take this wave, and take this wave. Right? Very evident, big waves. So what's the distance between both of them? Right? Roughly. This is 1 and this one. So this is 1 big box, this is 2nd big box, this is 3rd big box, 4th box. So 1, 2, 3, 4. That's right, right? This is 4 big boxes, so 300 divided by, we have got 4 cardiac cycles, right? We have got this 4 big squares. So our one cardiac cycle is of the size of 4 big squares divided, and the heart rate is about 75 per minute. Is this part clear? Everyone? Bolo yaar. Okay, chalo. If you are not, there is no answer, so I am considering below that. But this is not accurate. This is not accurate. To make it still more accurate, what if we calculate small boxes? Then that would be much better. Right? And if we say small boxes, then we have to change, make a small change. And that change is very logical. Same thing, but over here it would be 1500 divided by number of small boxes between 2 consecutive waves. Same example again. Now when we calculate, so we say, okay, in this case, so it won't be making much of the difference, but still, this is 1 plus there is 1 box here, small box. This one, and then there is 1 small box. So here we have got the 5, 5, 5, 5, 2 small boxes, 1 small box. So now this is coming to 20 and this is 23. So if we do it like 1500 divided by 23. So let's pull up again. 1500 divided by 23. And this is coming to 65 point, right? So 65. So roughly, this is coming to 65. See the difference? Correct. So that's the thing. So when you are calculating smaller boxes, it is giving you more accuracy. Right? Bigger boxes, when you just want to take a generalized idea. Right? When in case of emergency, it really doesn't matter few beats here or there, then you go for it. But these are the 2 methods and these are the 2 principles which you need to know. Chalo, let's ask. Fatafat bolo. I want at least some answer because I can see that just 7 or 8 friends are answering. I told you participate. Answer, fatafat, answer. What's the heart rate? I'll just zoom this thing. It's still easier. लो नहीं नंबर दोस्त नंबर बोल मतलब लो तो formula is 300 divided by big boxes between 2 waves or 1500 divided by small boxes. Correct. So that's like, that should be the answer, like around 36, exactly, 35, 36. Correct. Because beat would be always in that some number. So everyone, around 35, 36, you are right. You're right. Now don't you think that this is just too less? You know? Normally, apna heart rate is about 72. But over here, to we are, see, all of you are correct. Those who have answered 35, 36, right, 38, it's all correct. Okay, chalo. I'll do that. Right? How many big boxes? Right. First, let's calculate. This is one big box. This is the second one. This is the third one. This is fourth one. This is fifth one. This is sixth, seventh, and this one is eighth, and it is almost there. Right. So this is 1, 2, 3, 4, 5, 6, 7, 8. 8 big boxes, and then we have got 1, 2, 3, or 4. So 43 or 44, right? So just how much is coming out? So 1500 divided by 43. So 34.8 or 35, 36. All good. Got it? So one beat here or there won't make any difference. Right? It is all good. So let's keep it, say 35 or 36. All. But the point is, don't you think that this is just too less? You know? This patient this patient is, in fact, is absolutely healthy. Again, he came only just for a routine checkup. And now we are telling him, boss, you are having bradycardia, get admitted. Where do we answer? You answer in this chat only, because I can read all your answers. So, Durgesh, you just type in this chat only. So this is a normal patient. But normal patient, he won't be having such low heart rate. In such low heart rates, they are possible if you are into extreme athleticism, and on total rest. Then the tennis player, Bjorn Borg, right? He was having the resting heart rate of about 36. But it is very difficult to take the heart rate to that low level. It is exceptional. Well, this is like a normal patient. What has really, no, fat person, it has got nothing to do. Fat person, then fat person at times, lazy person have such, no, lazy person will be having higher heart rate. Lazy person will not be having slow heart rate. Only the efficient heart will be beating slow. Makes sense, no? Because if the heart is not efficient, then heart has to beat fast to push the blood into the brain and the rest of the body and the heart. Right? Because heart itself will be requiring the blood. But if the heart is efficient, then every stroke will be so powerful that it need not beat that fast. That's why it is said that when you exercise, there will be increase in the heart rate. But when you will take rest, then your heart rate will be much lower. That is the reason that your resting heart rate, RHR, is your fitness level. Your resting heart rate is what? Because your resting heart rate, then when you are not doing any activity, aram se you are shanti se, aram se you are sitting, so then your heart is beating it. So at what level it is beating? So that is this resting state. From that point, right, he can really go how much higher. If someone's resting heart rate is 72, that means by the time if it touches 100, then it is like increase of almost 30%. Right? But if someone's resting heart rate is 60, so then see, it is like 30% high is what? He'll be just 78, 80. Right? And just by 80, while doing meditation. That's why meditation is considered as very good after every exercise. Right? In fact, after every day, after every exercise, yes, the meditation is very powerful. Lower efficient heart has more due to less blood pump, so perfectly fine, absolutely. Less efficient heart, right? So he'll be able to pump less blood. Brain though is absolutely selfish. Brain tells you, to hell with the heart. I need blood. So it will say, you beat fast. The signals will come from the brain and will tell you, beat fast. We need blood. Right? So that's how it really goes. Now in this case, what really happened was this person forgot to do the calibration. Technician forgot to do the calibration. Right? So over here, the paper, when we say the paper should move, it should be how much? It should be 25 millimeter per second. That should be the pace. What really happened in this case is there is a setting. Sometimes you have to take such ECGs, but this is exceptional. And when the heart rate is extremely high, you run the paper also fast so that you can see the waves properly. Right? But then you know that I'm moving the paper at a double the pace, so I have to double the heart rate also. Right? So over here, nothing has happened. By mistake, the paper movement was not 25 mm per second. The paper movement was 50 mm per second. So that's why everything was spread. Right? Everything was spread. So that's why the whole thing spread. The real heart rate into 2 was about 70, 72. Right? Completely normal. So this is the importance of calibration. Similarly, if the voltage calibration is not done, so see here the voltage calibration has been done. So usually say this is about 1 millivolt, right? 1 millivolt. So this is about 2 big squares, and it is pretty good. But so there is a standard paper size. There is a standard paper size, right? It is a roll. It is a roll, and that keeps on moving. Even if someone is taking digital ECG, so in that also all these settings are there. But because those settings, as soon as you press normal now, so then speed and the voltage, they are automatically set. So things have become much easier because there is so just press of one button and it goes. You want to take a high speed ECG, so you just press it, so then ECG will be spread, and you can even control it how much you want to spread. So, but knowing these things will improve your vision. Yes, these are the things which can really occur. Tell me the heart rate in this. Don't worry about there are not so many abnormalities. Tell me the heart rate. I'm just zooming it. Yeah, take this part. Heart rate. You have to pick up 2 consecutive waves. So right now, don't worry about which waves are there. There is some abnormality. There is a myocardial infarction. All good. Okay. Good. Am I 27? How come? No. Think again. Things are not that difficult. 27 कैसे? Wait. Why such answers are coming? Arre. So, Guru Shri, right, Edonia, Atharva, Nirmal, Swastika, Shravani, okay, Muzama, Lati, correct. Durgesh, right, Rishabh, fine. Then I calculate again. Yes, Mohammed, right. You are right. Here, you are right. Tanmay, tell me the answer. 27. How did you came to this 27? This is one wave and this is the second wave. But this is one wave and this is the second wave. Roughly we take one big square, second big square, and third big square. So 3 big squares. The formula was, it's not symmetric to the heart rate. So that's why I say, right, it is quite regular. Right? Even if you calculate over here, almost 3 big squares are coming. But yes, it will. But let's take this. So 300 divided by 3. So roughly 100. I mean, if you take the small squares and then, yes, it might come to 107. Yes, right, it might come to 107 because instead of this exactly 25, right, it might come to, so it might come to this 555, it might come to 14. So when you give 1500 divided by 14, so that will come to that number, right? It can come. But roughly, so anyone who has answered in the range of 100, 107, all good. 14 small squares is 107. That's fine, right? So that is 107. So 100 is correct, 107 is correct. The idea was that, yes, how you really calculate, right? So this is what is okay. We quickly go through, or let's do this thing on Monday. Monday kya? Dashara, day after tomorrow. अरे क्या सॉरी, इसमें क्या सॉरी? चलो, one more. Answer this. This is a wonderful. So many pathologies are there. We'll learn this thing, but abhi ke liye, give me the heart rate. Let's take this heart rate. Excellent. Majama, Shweta, excellent. Very good. Tanmay, Shravani, Khushi, Kritika, Faiz, all are correct. Just let it excuse me for a second. I'll be back in. One. So 1, 2, almost 2 big squares, right? We can say this is 1 big square and this is 2, roughly 2 big squares. So becomes easy, 300 divided by 2. So heart rate is 150. Yes, this is tachycardia. This is tachycardia. Heart rate is pretty high. And in this, you must have noticed 2, 3 important things. One, see the P wave, right? This is P, this is Q, this is R, this is S, super spike in T, and then almost immediately in the next P. And then there is some error, right? There are some things which are occurring. Similarly, can you really see this elevation, right? This is what? This is Q, this is R, this is S, and then the T wave. This is the ST segment. ST segment which is disturbed. And in this, see what happened. This is your P wave. That's the Q. This is your R, S, and the T wave of your patient is spiking even more than the R wave. No, he is not an athlete. This is myocardial infarction, heart attack. It is in progress. Calculate this heart rate. Now you must be very efficient in calculating this. Zoom? Sure. Rafat. Very good, Durgesh. Mojama, calculate again. The rest, all of you are Tanvi, Solar, Jaya. Not audible. Mohammed, you are right. Vedant, Atharva, Arya, Susika, and then all right. All of you are right. It is easy, no? This is 1, 2, 3, 4. 4 big squares. 75. Anyone who has written 100, right, to know, just see that thing. It cannot be 100. If you're calculating small squares and you come to 77, Shavani, you're right, no problem. Calculating this. Fatafa. This is so very good. The crystal clear, seen so clearly. Nirman, think again, beta. Think again. Yes, all swollen. Purvashri, 375, this patient would die. That is called as the atrial flutter. It is even more than flutter. Bacha, calculate again. It is not 30, it is not 375, it is not 150. Array. I speak only incorrect answer. No, it cannot be 125. Just calculate. Simple. Itna calculate karo. हाँ, 56 चलेगा. 56 is okay. मतलब I mean when you are calculating small squares, that's fine. Great. See, one big square, second big square, third big square, fourth big square, fifth big square, right? Yes, to be accurate, yes, we have to calculate this one extra square also. But let's say roughly we want to do it. So one big square, two square, 3, 4 and 5. 5. 300 divided by 5. Kitna aata hai? 60. That should be your heart rate, right? In this case, your answer should be somewhere around 60. Exactly. You're right. Around 60. Plus minus. 2-3 idhar udhar. Yes, Shweta. 57 to 60. All are right. But 375, my friend, how did you get that number? And 25, how did you get that number? And what was one more answer? 125. No way. No way. Right? I'll not take the name now. If you have answered these, please calculate again. Right? And if in case of any problem, just ask. 60 is fine. Chalo, one more. Calculate this. A completely bizarre. Wait, let me give you a better one. Take this. Take this. Now, in this, don't take this section, right? And don't take this section because it is totally different. So take this much and calculate. Ishita, just calculate again. Here, calculate again. This is one big square. This is another big square. And the third big square is getting completed over here. So we are over here. Right. That's our input question. Correct. No, it cannot be 90. See. Okay. So if we just take this, right? So this is like 5. This is 5. And let's say this is 3 dots. So this is if it becomes 3. Right? If it becomes 3. So then 1500, right? We are taking small squares. And over here, say 5, 10, and 3. So divide by 30. So it is coming to 115, roughly 150. Got it? Yeah, Kushi. That's okay. So now you are right. Okay. Acha. Calculate in this case, if you are given this part, calculate. Now, every time you need not take above. Sometimes it happens. If it's like this, then you can take even these lower waves also, right? Whatsoever is more consistent. Like 300, just see this. उन्नति 60 कैसे? Those calculate again, yaar. Okay. See. यार बोलो ना पहले. See, very easy. खुशी. This is one box. पता चला. Right. This is the second box. Now what we are measuring is this point. Right. Let me make the pen still thinner. This point and this point. Okay. So we can make a judgment. यहाँ पे से this is one full box. This is where the other box is there. So this is about 2. You take 2 small squares? 2 small squares. Correct? So total 5 plus 2. So that means we are dealing with 7 small squares. So now you are smart enough. 1500 divided by 7. कितना आता है? Here. So 1500, 214. Yes. So here you are right. This is 250. So roughly down 200. Correct? Okay. Because these are the, and here even the indication is also, see, alarm pause. Right? Which alarm are we talking about? Because this is like when this thing happens, there are automatic triggers, right? So alarm goes. So alarm was paused, and then the ECG was taken. Last one. Calculate this. Now here, everything is normal, right? It is not so that the calibration problem is there, but this is one very major condition we'll study next time. But give me the heart rate. Good. Durgesh, yes. Atharu, that's right. Then the normal, yes. All are right. Good. Yes. Everyone right? So there it is, 1 box, 2 box, 3, 4, 5, 6. That's right. So here 300 divided by 6, that comes to 50. Right? That's right. This is typical. And if you calculate one more, it will be, if your answer is coming to 48, then also it is perfectly fine. 48, 46. Absolutely. Yes. So this is the SA node block. So now the AV node has taken over. Right? When the AV node has taken over, that's why you'll find that the P waves, they are almost, P wave have disappeared. Where is P wave? No P wave. Right? Straight away this QRS is coming. Right? So we'll study in more detail. But the absence of P wave, because P wave is created by atrial depolarization. And for the atrial depolarization, when the SA node fires, so SA node gives to this right atrium, and via Bachmann's bundle, it gives it to left atrium. When SA node itself is not working, so that's why over here AV node is working. AV node won't be firing in the reverse way, right? It won't go up. So AV node will be firing just below. And that's how it really goes. And that's why we are finding that P waves, they are almost somewhere they are seen. So it is like occasionally, somewhere the P wave is seen, a very weak P wave. Right? So randomly, sometimes the SA node, see over here, there is a P wave. Right? Randomly, it suddenly wakes up and it fires. And then once again, it is not fired. We'll see that. The total SA-AV dissociation. All right. So next time, that is on the day of Dashara, right, we'll be going into more details of many of the ECGs. One of the most fantastic things which we will learn is that is when you'll be able to visualize the heart, that the heart which is sitting inside, just by looks of the ECG, how he is sitting. So today you learned those basic concepts, plus the movement of the paper, plus the calibration, plus how to calculate the heart rate, right? Okay, so see you next time, and let's not write thank you. Thank you, thank you so much, and see you soon. Take care. Bye-bye. Wish you also a great day ahead. You send your support. I think I have replied to you, but if not, just send me again. As far as I know, send it to me again. Send it. Right? I'll see it today. All right. Take care. See you soon.